These special cardiac cells are responsible for conducting signals that cause our heart to contract. The first special cell is the SA node or the sinoatrial node. This is also known as the natural pacemaker of the heart because this is where the beginning of the conduction takes place. From the SA node, the conduction system goes to the AV node or the Atrioventricular node. This is also known as the gatekeeper of the heart because it gets to decide what impulse to let through. If the SA node generates a weak impulse or fails to generate an impulse at all, the AV node will perceive that and decide not to let that weak impulse go through, and instead, it conducts its own impulse. From the AV node, the conduction goes through the single structure called the bundle of His, and from the bundle of His, the cells will continue to then bifurcate to the left and to the right. These will now be called the left and right bundle branches. From the bundle branches, they will continue within the apex of the heart and will now be called the Purkinje fibers. This is the conduction system of the heart. And when the conduction goes from the SA to the Purkinje fibers, it will generate a heartbeat. Inherent heart rates are the heart rates that are generated depending on which cardiac cell sends an impulse. If the impulse starts from the SA node and goes all the way to the Purkinje fibers, this will generate a heart rate of 60 to 100 beats per minute, which is the normal heart rate. However, if the SA node fails, then the AV node will generate its own impulse, and this will give us a heart rate between 40 to 60 beats per minute. If the AV node is not able to function at its normal rate, then the ventricular pacemakers located in the bundle branches and the Purkinje network will become the initiating pacemaker. The inherent ventricular rate is 20 to 40 beats per minute. The AV junction only acts as a pacemaker of the heart when the SA node is not firing normally or the impulse is blocked. The AV junction is composed of the AV node and the non-branching bundles. Rhythms originating in the AV junction are called junctional dysrhythmias, which is our topic for today. I hope you guys understood the overview I made in the conduction system. Now that we understand what the conduction system is and how junctional dysrhythmia occurs, it is easier for us to grasp what it is. From what we learned in the conduction system of the heart, junctional dysrhythmias refer to the cardiac rhythms that are generated from the area around the atrioventricular junction node. For a variety of reasons that we will discuss later in the pathogenesis, the area that surrounds the AV node may generate impulse and become the cardiac pacemaker. The inherent rate of the junctional tissue is 40 to 60 beats per minute. When the junctional pacemaker paces at its inherent rate, it produces what is called a passive junctional rhythm or a junctional escape rhythm. Junctional dysrhythmias may include premature junctional complexes, non-paroxysmal junctional tachycardia, and the AV nodal reentry tachycardia. Let's first discuss the premature junctional contraction. This premature contraction is also called a complex and is a contraction that occurs early and before the next normal sinus impulse. It is an aberrant impulse that originates in the AV junction and occurs prematurely before the next expected P wave. This prematurity can make the rhythm irregular. The premature junctional complex may have any of these characteristics. Number 1 is that the rhythm is mostly irregular. Number 2, an inverted or absent P wave and a short PR interval. Whereas the QRS complex is usually normal and generally consistent in shape or morphology with other QRS complexes. The main cause of premature junctional complexes and premature contractions in general are the 3 S's: the stimulants, sepsis, and stress. Stimulants like caffeine, cigarettes, and alcohol can cause PJCs. Hyperthyroidism can cause premature contractions as well because increased production of the thyroid hormone forces the heart to work harder than usual, which increases heart rate and raises blood pressure. Digoxin toxicity or an overdose of digoxin can cause overcontractility of the heart as well. Sepsis or the infection of the body, like rheumatic fever or Lyme disease, can cause PJCs because of the initiation of acute inflammatory process may involve the conduction system. And lastly, stress, like anxiety from the normal daily emotional struggle. Not only that, but also disease that put added stress and inflammation to the heart, like CAD or coronary artery disease. The narrowing of the coronary arteries in the heart adds stress to the heart. Chronic obstructive pulmonary disease also makes it difficult for the body to get oxygen, which basically adds stress to the heart. Lastly, electrolyte imbalances like hypokalemia or low potassium can cause electrical problems like premature contractions. Premature junctional complex occurs when electrical activity in the SA node is blocked or less than the automaticity of the AV node. When this happens, there is an increased automaticity of the AV ectopic pacemakers, which initiate and depolarize the myocardium. This causes early depolarization of ectopic focus, and thus premature junctional contractions occur. PJCs are usually asymptomatic, however, anxiety, palpitations, and shortness of breath sometimes manifest. For palpitations, there is elevated blood pressure and heart rate upon assessment of vital signs, cold clammy hands noted upon palpation of skin integument, and abnormally rapid or irregular beating of the heart noted upon auscultation. Nursing diagnosis is risk for decreased cardiac output related to altered electrical conduction. Nursing management for this is to monitor vital signs, assess adequacy of cardiac output and tissue perfusion, noting significant variations in BP or pulse rate and level of consciousness, as well as to determine the type of dysrhythmia and record or document with rhythm strip. For shortness of breath, physical assessment includes the use of accessory muscles noted during respiration upon general assessment. Nursing diagnosis is ineffective breathing pattern, and nursing management includes to assess and record respiratory rate and depth at least every 4 hours. Another nursing management is to assist patient or instruct the patient to sit upright to maximize lung expansion. The next is anxiety. Physical assessment includes cold, clammy hands noted upon palpation of skin integument. Nursing diagnosis is anxiety related to lack of knowledge on health status and disease state. Diagnostic procedure for premature junctional complex is the electrocardiogram. Treatment modalities is treatment is usually not required, but people may opt to do lifestyle changes. For pharmacological management, they are usually not required. However, beta blockers and calcium channel blockers may be prescribed. Also, there is no possible complication for premature junctional complex. The prognosis is good, it generally doesn't manifest symptoms and does not require any treatment. Underlying diseases that cause PJC should be treated instead. Now let's go to non-paroxysmal junctional tachycardia. Non-paroxysmal means the dysrhythmia from the AV junction is not violent nor sudden. Non-paroxysmal junctional tachycardia is also called accelerated AV junctional rhythm and is a form of supraventricular tachycardia or SVT that is caused by enhanced impulse formation within the AV junction rather than by reentry. Reentry basically refers to the propagating impulses that failed to die out and is in a continuous activity around the circuit to re-excite the heart. During this rhythm, the atrioventricular node is firing faster than the sinus node, resulting in a regular, narrow, complex rhythm. NPJTs are caused by enhanced automaticity in the junctional area and has a rate of 70 to 120 beats per minute. Similar to premature junctional complexes, Although this rhythm generally does not have any detrimental hemodynamic effect, it may indicate a serious underlying condition such as digitalis toxicity, myocardial ischemia, hypokalemia, or COPD disease. Non-paroxysmal junctional tachycardia is also usually due to recent aortic or mitral valve surgery and acute myocardial infarction. Now let's go to characteristics. NPJTs have narrow complex rhythm with a rate of 70 to 120 beats per minute and retrograde P waves that are usually inverted in ECG findings. Non-paroxysmal junctional tachycardia happens when electrical activity in the SA node is blocked or less than the automaticity of the AV node. This causes an increase in automaticity of atrial and ventricular myocardial cells and initiate and depolarize myocardium. This causes repetitive impulse initiation or depolarization-induced automaticity in the heart, which causes non-paroxysmal junctional tachycardia. Non-paroxysmal junctional tachycardia has signs and symptoms which include headache, dizziness or lightheadedness, and shortness of breath. For headache, physical assessment includes facial grimacing noted upon general survey. Nursing diagnosis includes acute pain related to increased cerebral vascular pressure. Nursing management includes to encourage and maintain bed rest during acute phase, or provide recommended non-pharmacological measures for relief of headache such as cool cloth to forehead, back and neck rubs, and relaxation techniques, as well as to administer analgesics as prescribed. For dizziness or lightheadedness, nursing diagnosis is risk for decreased cardiac output. Nursing managements include assess the physical activity level and mobility of patient, and to take resting pulse, blood pressure, and respirations, and consider the rate, rhythm, and quality of pulse, as well as instruct the patient to perform activities more slowly in a longer time with more rest or pauses or with assistance if necessary, as well as to continuously monitor vital signs. For shortness of breath, physical assessment includes increased respiratory rate upon assessment of vital signs and use of accessory muscles noted. Nursing diagnosis includes ineffective breathing pattern, and nursing management includes place patient with proper body alignment for maximum breathing pattern and to encourage frequent rest periods and teach patient to pace activities. Other signs and symptoms of non-paroxysmal junctional tachycardia include racing heart, shortness of breath, sweating, headache, dizziness or lightheadedness, and fainting. Diagnostic procedures or lab procedures include electrocardiogram, blood tests to check for conditions like heart disease, or chest X-ray for pictures of the lungs and heart. Treatment modalities include lifestyle changes, at-home treatments such as dye reflex and Valsalva maneuver or carotid sinus massage, and also catheter ablation. Pharmacological management include calcium channel blockers and beta blockers, both of which reduce blood pressure, as well as amiodarone, which is an antiarrhythmic medication used to treat or prevent irregular heartbeats, may be prescribed. If not identified promptly, complications such as syncope, fatigue, and dizziness can occur. As for the prognosis, no evidence suggests increased mortality, so the prognosis of NPJTs is good. Now let's go to atrioventricular nodal reentry tachycardia. This is a common dysrhythmia that occurs when an impulse is conducted to an area in the AV node that causes the impulse to be rerouted back into the same area over and over again at a very fast rate. Each time the impulse is conducted through this area, it is also conducted down into the ventricles, causing a fast ventricular rate. Atrioventricular nodal reentry tachycardia, as the name suggests, is tachydysrhythmia caused by a reentry circuit in the atrioventricular node, or the AV node. In AVNRT, There are two atrioventricular nodal pathways. Patients or clients can have two atrioventricular nodal pathways and be fine. However, some people have a slow and fast-conducting atrioventricular nodal pathway. A fast-conducting pathway has rapid conduction but slow refractory period, whereas a slow-conducting pathway has a fast refractory period and slow conduction. The difference in the slow and fast-conducting pathways can trigger AVNRT. There are two types of AVNRT: the slow-fast AVNRT, which is the most common, and the fast-slow AVNRT. For the slow-fast AVNRT, the impulse travels along the slow pathway and fast along the fast pathway. The impulse traveling down the fast pathway will eventually excite cells at the bundle of His, but also in the slow pathway. This fast impulse will just cancel out the slow impulse in the process. The next impulse that travels from the sinoatrial node will enter the slow pathway first. Because the refractory period here is fast and the cells are able to get excited again, because of this, the impulse traveling down the slow pathway may eventually re-excite fibers along the fast pathway and the bundle of His. The impulse will travel rapidly backwards along the fast pathway retrograde to the atrium and also re-enter the slow pathway again, causing a re-entry circuit that will continue causing simultaneous ventricular and atrial contractions. Here in the fast-slow AVNRT, the opposite thing happens, and there is anterograde conduction by the fast AV nodal pathway and retrograde conduction by the slow AV nodal pathway. For characteristics, the ventricular and atrial rate during AVNRT is usually 150 to 250 beats per minute and 120 to 200 beats per minute respectively. The rhythm is regular with sudden onset and termination of the tachycardia. QRS shape and duration is usually normal but may be abnormal. P wave is usually very difficult to discern. If the P wave is in front of the QRS, the PR interval is less than 0.12 seconds. Factors associated with the development of AVNRT include caffeine, nicotine, hypoxemia, and stress, as well as underlying pathologies that include coronary artery disease and cardiomyopathy. The clinical symptoms vary with the rate and duration of the tachycardia and the patient's underlying condition. The tachycardia usually is of short duration, resulting only in palpitations. A fast rate may also reduce cardiac output, resulting in significant signs and symptoms such as restlessness, chest pain, shortness of breath, pallor, hypotension, and the loss of consciousness. For shortness of breath, the physical assessment includes increased respiratory rate upon assessment of vital signs and use of accessory muscles noted. Nursing diagnosis is ineffective breathing pattern. For nursing management, place patient with proper body alignment for maximum breathing pattern. Encourage frequent rest periods and teach patient to pace activity, and also encourage deep breathing exercises. For chest pain, nursing diagnosis is acute pain related to increase in cardiac workload. Nursing management includes assess vital signs and symptoms of pain such as facial grimacing, rubbing of neck or jaw, reluctance to move, note onset, duration, location, and pattern of pain. Another is to use pain rating scale to assess the patient's perception of pain severity and to administer sublingual nitroglycerin as ordered. For loss of consciousness, physical assessment includes cold and clammy hands noted upon palpation of skin integument, and also patient reports feelings of nausea, tunnel or blurred vision, and confusion or disorientation. Nursing diagnosis includes risk for falls related to episodes of loss of consciousness. Nursing management includes to assess mental status changes, confusion and impaired judgment, increase patient's chance of falling. Another is to move items used by the patient within easy reach such as call light, urinal, water, and telephone, and also to use side rails on beds as needed. and guarantee appropriate room lighting. For hypotension, physical assessment includes decreased blood pressure upon assessment of vital signs. Nursing diagnosis includes decreased cardiac output related to altered heart rate and rhythm. Nursing management is to assess and document the following: mental status, lung sounds, blood pressure, heart sounds, urine output, and peripheral perfusion. Also, keep client on bed in semi-Fowlers and administer high-flow O2 via nasal cannula as prescribed. Because AVNRT is generally a benign dysrhythmia, the goal of medical management is to alleviate symptoms and improve quality of life. Patients who become significantly symptomatic and require emergency department visits to terminate the rhythm may want to initiate therapy immediately. However, those with minimum symptoms with an AVNRT that terminates spontaneously or with minimal treatment may choose just to be monitored or self-treat. The aim of therapy is to break the reentry of the impulse. Catheter ablation is the initial treatment of choice and is used to eliminate the area that permits the rerouting of the impulse that causes tachycardia. Vagal maneuvers may be used to interrupt AVNRT. These techniques increase parasympathetic stimulation, causing slower conduction through the AV node and blocking the reentry of the rerouted impulse. If the vagal maneuvers are ineffective, the patient may then receive a bolus of adenosine to correct the rhythm. This is nearly 100% effective in terminating AVNRT. Because the effect of adenosine is so short, AVNRT may recur. The first dose may be followed with a larger dose or with a calcium channel blocker such as verapamil, followed by 1 or 2 additional boluses. For recurrent sustained AVNRT, treatment with calcium channel blockers such as verapamil and diltiazem, Class 1A antiarrhythmic agents such as procainamide and disopyramide, Class 1C antiarrhythmic agents such as flecainide and propafenone, and Class 3 agents such as sotalol and amiodarone may prevent a recurrence. Possible complications include hemodynamic compromise, congestive heart failure, syncope, tachycardia-induced angina, and myocardial infarction. The prognosis for patients with atrioventricular nodal reentry tachycardia is usually good in the absence of structural heart disease. Most patients respond acutely to vagal maneuvers or adenosine and long-term to medications to prevent recurrence or to radiofrequency ablation, which is approximately 95% curative and low risk of complications. And that's the end of our topic for today. I hope you guys learned a thing or two about junctional dysrhythmias. Again, my name is Althea Mosende and thank you for watching.